DIC, you will find, is not all that common of an occurrence on our unit, but it really should be considered an emergency and dealt with in an urgent and emergent fashion while mobilizing all the major resources that our hospital has to offer, such as ICU and the massive hemorrhage protocol. Because although it is rare, it is very life-threatening, especially to our obstetrics patients. So before you go any further, watch the YouTube video on DIC that I have linked in e-learning, because it will describe a bit of the clotting cascade and what normally happens. I'm going to talk about why our obstetrical population is particularly at risk for DIC. So just as a review, it is an acquired syndrome, meaning you're not born with it. It doesn't happen sort of quietly on its own for no particular reason. It's a formula that equals an underlying pathology plus a trigger. And in the wrong combination, in the wrong type of patient, it will cause DIC. So you first need an underlying pathology, and you then need a trigger. Well, what does it cause? It causes activation and overstimulation of the clotting and bleeding processes within our blood vessels. So the clotting system is extremely complex thing to understand, but just basically the body is shocked and the clotting system gets confused and overwhelmed, and then you start seeing the DIC. So both at the same time, the body is clotting, which leads to clotting off of the major organs. So you get organ and tissue necrosis, but also at the same time, the body is bleeding. So you end up with hypovolemic shock and anemia because the patient is rapidly losing red blood cells. When we think about red blood cells, we want to think about what is the job of red blood cells. The job of the red blood cells, the hemoglobin, is to transport oxygen to every organ and tissue of the body. So red blood cells, hemoglobin, are thought of as oxygen carrying capacity. And when we don't have enough oxygen carrying capacity, literally not enough vehicles to transport the oxygen around, we end up in a state of hypoxia, both in all of our organs and in our system in general. So in the general population, who gets DIC? It would be cancer patients, septic patients, major trauma patients, because there's so much bleeding, internal bleeding that can't be controlled. These type of people are more prone, but let's look at our obstetrics population. So the first person that really discovered DIC was a person named Dr. DeLee in 1901. And he described it as obstetric calamities. What he noticed is that the patient was bleeding. So that would be what he described as a temporary hemophilia. He didn't know how else to describe it, but by something he already knew of, which would have been hemophilia. And who was his patient? His patient was abrupting. She had an IUFD sitting in utero for a prolonged period of time. So in this case, it would be sepsis and or a placental abruption because of the IUFD, and that is what triggered her DIC. And so here's the formula for DIC. So you first need an underlying pathology and then a trigger. Then a highly coagulable substance enters maternal circulation. Something gets in the bloodstream that is not supposed to be there, and that really, really irritates the body. The compensatory mechanisms of the body are completely overwhelmed and incapacitated, much like sepsis. The body is just overwhelmed. And then you have two processes happening. You have clotting and bleeding at the same time. So what is an underlying pathology for our patients? It could be the pregnancy alone. Pregnancy is considered a state of wellness, but it can be a state of illness for some people. So it's the wrong combination in the wrong person. So it could start with the pregnancy and then develop into something else. Like she could develop hypertension. She could start bleeding. She could start bleeding from a previa. She could start bleeding from a placental abruption. That's a lot of times we don't know why people abrupt. Or she could have an IUFD, which was described earlier. Even just a simple pre-labor rupture of membranes is a risk of getting an amniotic fluid embolism. And that is a highly coagulable substance that enters the maternal bloodstream, and it is extremely irritating to the body, as we will discuss. So the people most at risk will find 37% of people that get DIC in our obstetric population have abruption. So abruption would be the leading cause, followed by PPH or hypovolemia, a hypertensive disorder, and less rarely acute fatty liver, which you'll read about in the liver presentation, any type of infection, all the way up to sepsis, and then amniotic fluid embolism. Very rare, but very dangerous. So what could be triggers in our obstetrical population? So really four main types of triggers. So bleeding, and we know that our obstetrical patients bleed. Anytime the body is irritated in any way, it causes inflammation. Could be an infectious process going on, will irritate the body and irritate the blood vessels. And then anytime there's endothelial damage. So this could be a large laceration, small laceration. This could be a vaginal delivery where she had a tear. You get endothelial damage with a C-section. All kinds of endothelial damage, and endothelium being the lining of the blood vessels. All types of endothelial damage occur during our deliveries. So what's a highly coagulable substance? So we don't need to know a lot about this thing called tissue factor. It is a substance that the body makes. Also, platelets are highly coagulable. Obviously, fibrin is part of the clotting cascade. If the baby and mom had an incompatible blood type and the baby's blood went up into maternal circulation at the interface of the placenta, that would be a highly coagulable, highly incompatible substance entering maternal circulation. And the mother's body would react very strongly. Could be a chunk of placental tissue that gets into maternal circulation, very small, minuscule piece of membrane, as well as amniotic fluid. So you can see how a lot of these things are occurring around the time of delivery, but something like infection and inflammation could be at any point during the pregnancy, and pregnant women get all types of infection, which also leads to inflammation. And so what you end up getting is the highly coagulable substance entering maternal circulation. You get activation of the clotting cascade, and the body does not like it. The problem with inflammation in the clotting cascade and any type of tissue damage or infection, all of that causes inflammation. Inflammation is very unhealthy to the body, and you end up with a vicious cycle in DIC of inflammation compounding the clotting cascade, and the two things together just make the whole situation even worse. So let's go through an example of how a placental abruption can cause DIC. So what happens during a placental abruption? The placenta is coming off the wall of the uterus, it's tearing off. And so you have damage at that placental bed site. You have damage to the uterine arteries, myometrium, and the placenta itself, so that damage of tissue will cause release of tissue factor, release of thromboplastin, platelet activation. Now that could just be the reason that causes DIC, but what if there was a fetal maternal blood incompatibility and that got into mom's bloodstream? That would also activate. Or just the fact if she's losing blood, hypovolemia and hypoxia could cause the clotting cascade and inflammation to get out of control, causing the clotting cascade to be overstimulated. Signs and symptoms. So we are looking for things that are never normal and sort of out of our comfort level. So our patients are going to bleed from an IV insertion site, but when does it get to be too much bleeding? When do you feel like that amount of bleeding from an IV insertion site or getting some lab work drawn is bleeding too much and you're putting pressure on it and the bleeding just won't stop? What if you catheterize her bladder and she's got bleeding from there? Is that normal? No, it isn't really normal. What if she's having a nosebleed? Not a lot of women around here. We don't really have problems with nosebleeds here. Is she bleeding from her gums when she brushes her teeth? Is there blood in her urine or her feces? All those things are not normal in our population. Another big indicator would be generalized oozing from a surgical site, maybe like a C-section incision that was previously hemostatic. So if all of a sudden she's saturated her C-section dressing, you put on a pressure dressing and she's saturating that, that is not normal. That needs to be reported to the physician. We need to keep a very close eye on this patient. But otherwise, if we're trying to make a diagnosis, there's no test, there's no light switch that flips on that says, oh, she's in DIC. What we would be looking for is a change in her blood work over a period of time. Let's say we're running a massive hemorrhage protocol, we're in the middle of a hyst, and we're sending lab work every 30 minutes, and we're noticing that her platelets are dropping. Her PTT and INR, the bleeding times are getting more prolonged. That's a clue that she may be going into DIC. So we're watching for clinical signs, we're watching for laboratory changes, and we put all that together with the clinical picture and we say, yeah, I think she's in DIC. There is no scale or scoring system specific for DIC, but we are going to use our MEOWS scoring and our maternal sepsis trigger tool that is going to tell us that her vital signs are outside of normal limits. Vital signs are going to be outside of normal limits probably, but her lab work as well, as I've mentioned. So we want to watch our patient and put the clinical picture together. What is the treatment? Correcting the underlying pathology. So if it's an IUFD, we need to deliver. Do we need to deliver by a dilation and evacuation? Maybe she needs a DNC. If she's abrupting, we need to deliver her. You know, does she need antibiotics because she's septic? PPH, obviously, we know the treatment for that. We need to aggressively manage a PPH, not prolong it. Otherwise, the only solution, there's no medication. The only solution is fluid resuscitation for hypovolemia and shock and massive hemorrhage protocol, replacing all the blood products that she's lost. Not just red blood cells, but possibly platelets, plasma, clotting factors, fibrinogen, everything that she is losing as she's actively bleeding out.